أروى.
لو مرحبا
هلا.
بروف.
أيوة، جاهزين؟
جاهزين، أيوة نبدأ.
خلاص. طيب، بسم الله الرحمن الرحيم. Welcome to this Sunday morning lecture, which is started as medicine in the tropics or tropical diseases, and then it is converted to medicine in the tropics, dealing with a lot of medical issues and comparing what happens in the tropics as what happens in the Western world. And we concluded that although the very classical diseases of tropical diseases are now more restricted and are being given enough care, infectious disease is still prevalent, but is still under control. However, there is an emergence of non-communicable diseases. And the WHO is now dividing the disease into two parts. Part one is the communicable, which generally is receding, is coming down, because we have very, very good tools, Vaccination is the major health intervention which saves life. Antibiotics are now available all over, and very, very good antibiotics. Surveillance and diagnosis of different infectious and tropical disease now available at hand. And we get the peripheral health system. We can get some very rapid tests of malaria, of other infections, which can help in quick diagnosis and treatment. So the non-communicable diseases are now getting on top of the list of diseases which welcome, which we do see from time to time. The non-communicable diseases accounts for 71% of the mortality of humans, 71. And most of it, 70% of this 71, is due to vascular disease or cardiovascular disease. So now we know where to put the money for control of diseases. We know how to spend money in health education, in changing lifestyle, and others which will decrease the mortality and morbidity. We dealt with cancer last time, neoplasia or malignant tumors, and we saw how the difference, not very much, but difference in certain tumors in Africa, for instance, and in the West. The major difference in the cancer is availability of very advanced drugs in the Western world, that cancer now is in 50% curable disease, which is an unfortunate state in tropical countries where availability of advanced drugs, availability of radiotherapy, advanced radiotherapy is not available, and people do succumb to cancer very easily in the third world. So we have these differences, and we can put it under the umbrella of low, medium income countries. It's not just the infection which is available. It's not just the tropical climate which is there. It is more than that. It is the society. It is the poverty. It is the overcrowding. It is the lack of education. It is the lack of potable water. It is inadequate and the lack of adequate sanitation. All these are adding up to the prevalence of disease in the tropics. Okay, just good nutrition and good care, good air can decrease the diseases. Tuberculosis, for instance, in Europe, decreased just by these measures of good nutrition, good care, isolation, earlier than the antibiotics came to control of tuberculosis. So changing in the habits, lifestyle, even for infectious diseases, can decrease the mortality and morbidity, let alone for non-communicable disease. And by and large, you can say non-communicable diseases is man-made, meaning that it is your style, it is your social life, it is your eating habits, it's your bad habits like smoking and drinking, it's lack of care about hygiene. All these will result in the non-communicable diseases. Okay, so the major non-communicable disease in the world is the cardiovascular diseases, cardiovascular disease. When I say cardio, it's heart, obviously. Vascular is a vascular system, and these are affected. And then from it stems like cerebrovascular accidents or cerebrovascular. And the two major killers is ischemic heart disease and stroke. Among those non-communicable diseases, the major is ischemic heart disease and stroke. And when I say ischemic, meaning that that particular part of the body is not receiving enough blood. So this is what we want to do this morning, is to tackle one of the most important risk factors for cardiovascular disease, which is hypertension. I hope if I find time, I will also cover a communicable disease which affects the heart, which is rheumatic fever. Okay, so let us talk about hypertension. Hypertension is simply a raised blood pressure above the normal. Easy said than calculated, because up to now we have to address what is the normal blood pressure and how does it change from age, by sex, by environment, by ethnicity. So what is my normal blood pressure? So the way we do it is either by surveying a large population and seeing the distribution, the even distribution or the bell distribution of the blood pressure, and we say within that range, this is normal blood pressure. But the way people are doing it is by measuring risk or complications or morbidity according to the blood pressure at the start, at the baseline. So they take different levels of blood pressure and then they continue measuring, they continue estimating and evaluating the health of the individuals, and they see what is the level above which is more risk, more complications, and more morbidity. Okay, there are different associations and societies which are setting guidelines for hypertension, like the American Society of Cardiology, the American Society of Hypertension, European Society or Association of Hypertension and Cardiology. So it is different. But I would like to stick to the WHO, which is the UN agency, and we do respect it. So what they say as hypertension is any level of systolic above 140 millimeter mercury and or diastolic above 90. So this will put the systolic alone higher than 140 as hypertension. It can put the diastolic alone more than 90 as hypertension. It can put hypertension if both systolic and diastolic are higher than 140 over 90. Days gone by, we didn't used to worry about the systolic, and we are concentrating more on the diastolic. But nowadays it's very clear that systolic and diastolic bears complications. So this is now the accepted criteria for hypertension, 140 over 90. Okay, 10 million people die every year. 10 million people die every year because of hypertension-related disease. Hypertension-related disease. And the number of patients with hypertension has risen almost 100 times from the 70s to now to reach 1.1 billion people who are hypertensive. So you can imagine the burden of disease on the health system, hypertension. Luckily, hypertension is easy to diagnose, easy to monitor, okay? And now there are very effective and safe drugs, okay? In the 70s or 80s, there were very few drugs that can control blood pressure, and their side effects are even worse than the disease itself. Many people will not accept taking the antihypertensive. But nowadays, it's so simplified. The drugs are available, reasonable price, and they are easy to take with minimal side effects. Okay, so what is the difference between different populations or ethnicity? Is there any difference? Yes. If you look into the African nations or African, Black African, and for that purpose, Chinese as well, they have low renin activity. They have low renin activity, meaning that they are highly sensitive to sodium. They are highly sensitive to sodium. Secondly, as a response to drugs, certain drugs will work better in Africans, Black Africans, and some drugs work better in Caucasian or white people. This is known from the time of the 80s and 90s when beta blockers were used extensively as an antihypertensive. We knew that Caribbean Africans, British who are living in Britain, have more complications with hypertension than the others, and their response to beta blocker is less. I'm just drawing your attention to the fact that there is some ethnicity problem or ethnicity difference between different population in pathogenesis and in treatment when we come to treatment. And I hope I will come to treatment because there is a lot of development in that part. Okay, so hypertension is a lifestyle. It is an interaction between environment and genetics. People are more predisposed genetically to hypertension, and the environment plays a major role in the development of hypertension. Okay, we can talk about modifiable and non-modifiable risk factors for hypertension and for cardiovascular disease. And these are general. I mean, when I talk about this modifiable, I'm talking about hypertension, cardiovascular disease, stroke, and even cancer. All these are factors which are playing across the board in non-communicable diseases. Okay, one of them is obesity. If you are obese, then you have hyperactivity of aldosterone system, angiotensin aldosterone system, and this is hyperactivity can make you prone to develop hypertension. Okay, there is activation of sympathetic nervous system with obesity, and this is again may tend to accumulate more hypertension. Okay, so the obesity itself is not only a risk factor for hypertension development, but also for diabetes. So clearly obesity is a disease, all right, by itself, because it's associated. Even cancer, they have found that the rate of cancer in obese people are higher than non-obese people. Okay, the other risk factor is tobacco or tobacco. Okay, cigar. Okay, this is very important risk factor. And this is what we do on ourselves, okay? If there is a bug around, then this is natural or nature. But if we smoke and then we fall ill, then nobody to blame apart from ourselves. Okay, even one cigarette a day has been associated with mortality and morbidity due to cerebrovascular disease. Okay, even passive smokers, if you are living with somebody who is smoking, then there is a very high percentage of people who die, despite the fact they are not themselves active smokers, but they breathe the smoke from other people, okay, mainly people within a closed environment like families. Okay, and so it's nicotine is responsible of a lot of diseases. How does nicotine or smoke causes cardiovascular disease? We know it causes cancer of the lung, okay, because it irritates the mucosa and changing it into the epithelial type of mucosa, which will go malignant. But as far as cardiovascular disease, carbon monoxide is formed on smoking. Carbon monoxide. Okay, carbon monoxide gas is lethal. If you are closed in a room with carbon monoxide, then that is death. Okay, but here there is a small amount of carbon monoxide which is inhaled with the smoke and then carbon monoxide will link to hemoglobin, causing carboxyhemoglobin. And carboxyhemoglobin causes arterial intimal damage. So they roughen the intima, and roughening the intima is serious because then platelets can drop there and form a clot which will build up to close the artery itself. So carboxyhemoglobin is one of the substances, irritant substances, erosive substances, which is caused by tobacco, okay, or by smoking. People are getting around, it's just not smoking. Is it just the smoke you take, or is it the nicotine? This is why they now have nicotine patches on the skin. It gives you nicotine for those who are addicted of nicotine, and there is the chewable nicotine. You just chew it like a gum, and then gives you nicotine level, which will decrease the smoke. Okay, but at the end of the day, you are not safe at all unless you stop smoking. And then I would like to remind you of tobacco, okay, which is the stuff which is causing salivation. It's not a very sociable event, but again, that causes local abnormalities in the mouth, and it is a major cause of cancer of the gums, tongue, and palate. So, smoking has to be stopped, okay? And then there are dietary factors. What are the dietary factors which will help cardiovascular disease and hypertension? One is fat, meat, red meat, which is like lamb meat, full of cholesterol and dangerous lipids, which is the low molecular, low lipids, low density lipoprotein, low density lipoproteins, and lipoproteins are the carriers of the lipids. So fat is dangerous in meat. Okay, beta, you have high level of fruits and vegetables, and it has been shown that even those who are less eaters of meat, red meat, okay, more eaters of fish, more eaters of vegetables have less hypertension, okay? And if you go into the literature and see the Eskimos in the more north where they don't eat except the fish, then they have lower hypertension. Okay, saturated fats, we used to blame saturated fats, but now the evidence is less and less. Okay, why fish? Because now there is new evidence that omega-3 fatty acid, which is found in fish, is very healthy and lower the level of dangerous fat, leading to more physical fitness. Clearly, now we are talking about other confounding factors. I mean, when I talk about diet, about good food, about things, I have to consider poverty. Okay, this is what is now prevailing, poverty. And in a country, we find that more than 60% are below the poverty level. Okay, so if I'm asking them to eat, fish and eat vegetables, we have to consider the cost. But this is what we should aim at. Okay, physical activity. Physical activity is now becoming very important, and the more time you spend in physical activity, the better. But there is a minimum, okay, which is designed by WHO. It's about 150 minutes a week walking briskly. 150 minutes brisk walking. This can be done on 5 days, 30 minutes every day, 5 days, 30 minutes every day, okay, of moderate activity, which is brisk movement. Or you could have 20 minutes with vigorous like jogging, okay, vigorous exercise. So, and when you are in middle age and later, you need exercise more than when you are young. Okay, this is important, and it has been found that exercise will lower, okay, bad lipids or low density lipoproteins, and it will decrease the platelet aggregation. Okay, you hear about platelet aggregation. This is in the pathophysiology of vascular disease, platelet aggregation is extremely important. So that is the second thing is obesity, diet, okay, exercise, and then the comorbidity. What are the comorbidity factors which are relating to the cardiovascular disease? Okay, the comorbidity is if you have the two, then you get higher incidence of cardiovascular disease. Obviously, things like diabetes, okay, things like diabetes. Then if you are diabetic with hypertension, then that is more likely to give you cardiovascular disease, obviously, than if it is just hypertension. And there are family factors, okay, hereditary factors. Okay, anybody who comes with myocardial infarction, you have to ask about family history. If it is less than, if anyone in the family, near family, who have myocardial infarction below 50 or below 60, then that is a positive family history. But if it is above that, then that is what is not related. So family history, hereditary, and this is why I said it is an interaction between genomes and environment. It is an interaction between genomes and environment. So what are the non-modifiable factors? These factors which we cannot do a lot about. Sex, for instance, men are more prone to ischemic heart disease, and women nowadays are getting up on the level, on the ladder, or on the curve of myocardial infarction, particularly postmenopausal women. Okay, men used to smoke more than women, but now the trend is getting into equality or reverse. Women are getting more into smoking. Okay, the environment, there is definite factors and definite proof, and that the environment pollution is very important development of cardiovascular disease. Okay, and the noise, even the noise, or what you call metal contamination. Metal contamination is lead in the air, and cadmium, which is another metal or metal-like, and we don't know what is the effect of mercury vapors in mining, in gold mining, which is used in cleaning the gold mining, or in clearing the gold. So this is the non-modifiable factors: age, sex, genetic, hereditary, so we can't do anything about. Okay, environmental pollution, we can do, but it is not easy. Okay, noise, and most important, education and social inequalities. Okay, there is a lot of social inequalities in the world, which is really harming the poor. Okay, if you are educated, you are less likely to have disease, because then you can understand what brings disease, how to protect yourself, and if you are educated, you usually have the means of looking into a better life. Okay, hypertension. After we have defined what is hypertension, okay, and what is the level of hypertension, we would like to do the clinical part. And I'm always interested in talking about the clinical part of hypertension, because this is an area where a lot of things go wrong, all right? Secondly, if it goes right, the benefit is far more rich than others. Okay, with very minimal effort from doctors, communication between the patients and the doctor and the patient, between the doctor and the patients, then there is a lot of benefit. It has to be said that hypertension, according to the level which we set, is a non-curable disease. Let us be frank about it. It's not going to be cured, meaning that I cannot give you pills and then the blood pressure will disappear. Once the blood pressure has been confirmed to be high, then the patient will remain hypertensive for the rest of his or her life. That is very important information, and it doesn't get through. It doesn't get through to the patients. We did a study some time ago of patients with stroke. We found 1/3 of them are not aware of having hypertension, and 1/3 knew that they have hypertension, but they were not complying. Some of them complained that nobody told them that the drugs should be taken for life. So that is an important communication between doctors and patients. So that's number one, compliance, drugs for life. This is why when we are talking about drugs for life, is something which is continuing in the whole of my life. I worry about minor side effects. If I feel nauseated, or I have a rash, or if I has a bad night, or if I have impotence. All these are major concerns for somebody who is taking drugs for life. If you are taking drugs for a day, 5 days, 7 days, you can tolerate side effects. and get away with it, because the disease is then cured. But if it is for life, then good measurement has to be taken, okay, to give you the best option of the drugs. Measuring of blood pressure is easy said than done. It's easy said than done. We use the classical or the conventional mercury machine, which is available all over, and we use the automatic, which is the aeroid, okay, automatic. You just wrap it and then inflate, and then it gives you a reading, which is the blood pressure, systolic and diastolic. Okay, the precaution is, one, don't measure the blood pressure as the patient comes in, because usually he is anxious. It's important that he should be comfortable, okay? He should not be worried. And we talk about white coat hypertension. White coat hypertension is a clinic pressure or a clinic high pressure, okay? This used to be taken as lightly. It's not. Why do some people get into the room and get high blood pressure? Because they're anxious, and some don't. So you don't take it lightly that the pressure which you have seen is due to the fear of the patient from the environment of the doctor. But you have to insist on getting the patients repeatedly to repeat the blood pressure measurement and decide if the blood pressure is sustained. So hypertension is sustained rise in blood pressure. Okay, how do we do that? We measure it, and I usually prefer not to measure the blood pressure as the patient comes in. Okay, let him relax. When he goes to the couch, then he can relax and then measure the blood pressure like a normal routine detection of physical signs. Okay, and then he comes. If he has a high blood pressure, don't tell him at that time. You have to ask the patient to come repeatedly, at least 2-3 times a week apart. If on the third time, then this is sustained blood pressure. Okay, other ways to do it is to give a sphygmomanometer to the house, and now this is very common. Hypertensive patients, or hypertensive mothers have around offsprings, grandsons and daughters who are capable of measuring the blood pressure at home. So it's home hypertension. So if he measures the blood pressure for 7 days and sustained pressure, then this is hypertension. Okay, there is another method of what is called ambulatory measurement of blood pressure, and this is you just tie up, and then this is the give the machine, take home, and then we get a strip of readings all over the day for 24 hours, and you can see clearly if there is high blood pressure and if it is sustained. Okay, this is also done for arrhythmia. If you have paroxysmal arrhythmia and you don't know, if you go to the clinic and have ECG, then the heart may be normal. But if you go home, you have a lot of palpitations and irregularity. The way to do it is 24 hours ambulatory measurement of heart beats or heart rate. So this is another way of measuring the blood pressure. All we wanted to do is to say it is a sustained rise in blood pressure. Okay, we don't want to give somebody, on one reading or a careless reading, a careless measurement of blood pressure, drugs for life, because that means you are damaging his health and you are robbing his money. So that is the precaution. The other precautions on measuring the blood pressure is check the machine. More often than not, there is no care about these machines. Not only in the Sudan, but almost all over. Okay, the first thing is that it has to be tied, round carefully and put and closed when the box, the metal box is closed. It has to be closed. inflator, there is a small screw on the side of the screw. Don't make it up because then it presses on the glass and break it. So comfortably put the back, all right, or the cuff into the bottle or into the box, metal box. Okay, when you want to use it, open it up and then look at the mercury. The mercury may be columns of mercury, then air, columns of mercury. Yeah, this is not correct because it gives you wrong pressure. So you really have to shake it and put it down, okay, and read the zero. If the mercury is 0, then this is 0. Okay, from there, it measures the blood pressure. But if it is like 5 or 7, then if you have 140, you subtract 5 or 7 to start with, so it is not correct. So there is, it is important that you should get sure that the machine is calibrated at 0. And we used to have machines, okay, blood pressure, also is called random zero sphygmomanometers. This is, they start maybe at 10 or 12, you know, they go up and then they give you the reading subtracting the level it started with. But anyway, with these machines, you have to get it 0 level. Moreover, okay, when you do it, the arm should be resting. You should not hang the arm like that, okay? This is what we call isometric contraction of, and it gives you high blood pressure. Okay, so the arm should be at the level of sternal angle, the level of the sternal angle, the arm with the level of the sternal angle comfortably lying on a bed or a couch, you know, and then what will happen is you have the cuff, all right, palpate the brachial artery and inflate the cuff and see the pulse. If it disappears, go 20 more, 20 millimeters more, and then put the stethoscope in where the brachial artery, and then start listening. The first Kortokov 1 is the appearance of the beats, okay, and Kortokov 5 is the disappearance. We take the disappearance of the sound. Sometimes, like in pregnancy, the sound doesn't go, continues to the end. So we take it from the time when it changes the intensity, okay, which is 4, Kortokov 4. So that is the systolic, and then this is the diastolic. Okay, you have to deflate at a regular, don't do it like this, and do it gradually. And sometimes if you go down and then you go up, go down and up, this will give you wrong reading. So if you want to deflate, you deflate 2 millimeters at 1 second. Okay, 1 second, 2 millimeters regularly till you come down, okay, to the first sound, which is Kortokov 1, and then the disappearance, which is 5, and that is the diastolic. So that is the way to do it properly. You know, it's easy, but it is not taken as easy, and it can give you wrong diagnosis. It can give you wrong diagnosis if you don't do it well. Okay, and the wrong diagnosis here, it really matters. It really matters because you are putting this patient into danger of giving him drugs unnecessary and so on. Okay, what is the symptoms of hypertension? No symptoms. There are no symptoms. It's asymptomatic. It is asymptomatic. And this is, sometimes you get very high blood pressure in a patient, and then he comes, you know, you measure the blood pressure, you find it high, he has no complaint. Erroneously, some people will think that headache is hypertension, okay? Or headache, the complaint of headache leads to hypertension, the diagnosis of hypertension. The answer is no. There is, well, the trials which has been done hypertensive and non-hypertensive, about headache, they found no difference between those who have headache, who have normal pressure, and those who have headache with high pressure. So don't be fooled that the patient did not complain of anything, because hypertension is essentially asymptomatic, and unfortunately, it may present itself first by the complication of either stroke, all right, myocardial disease, all right, or peripheral disease, or encephalopathy if it is very high. So these are the complications. This is why people call it the silent killer. The silent killer. Okay, so this is what we call primary or essential hypertension. Primary or essential hypertension, where there is a multifactorial. It's a multifactorial, as we said early. Okay, the changes in the arterioles, macrovascular, microvascular, it changes stiffness, and this is lead to hemodynamic load is changed, and then this will precipitate more stiffening of the blood pressure of the arteries and give you blood hypertension. Okay, so it's multifactorial, the essential one. There is 5% only. 5%, 95% are essential or primary. 5% is secondary to some causes which we can highlight on them. Okay, so the how do we pick up patients' hypertension? If it's a silent killer, then we have to be proactive and get the patients who have hypertension. Okay, so the way we do it is, all doctors who have a patient in their clinic should measure the blood pressure, even if it is not indicated. If it's coming with abdominal pain, take the opportunity of measuring the blood pressure. If it's coming with leg pain or right knee or whatever, then you have to take the opportunity of measuring the blood pressure. Secondly, we advise that all people, especially above 40, should have a measurement of the blood pressure at least once every year. One every year. And nowadays, people are accustomed to having a checkup which is examination, ECG, maybe chest X-ray, and some investigations, which is done yearly. And clearly, if that is the case, blood pressure would be given enough attention. So it's picking it up. So being proactive and getting it into the light. Okay. Once this is diagnosed, on sustained blood pressure, measuring it more than once or twice or 3 times over 1 week interval, then the blood pressure is thought to be high, and this is hypertension, and you would have a long talk with the patient, long communication. Tell him about it, about the secondary hypertension, about how he control it, about the complications, about what he should do in his life, about his diet, about his sexual life, about his work, all this, and about the compliance of the drugs. It's extremely important, okay, to have that talk with the patient and encourage him, tell him that it is not curable, but as far as he is taking the drugs, he is safe, okay, or as safe as possible. And now there are a lot of diseases. AIDS is a killer, but if you give the drugs antiretroviral therapy, then the patient become normal, almost normal, okay? So this is the case with hypertension. Many patients will take the blood pressure, will have high blood pressure, then they take a drug for 1 month, and then they go to a clinic to say, well, I'm hypertensive, measure the blood pressure, and the doctor tells him that it is normal. So the first thing he does after he exits the clinic, he drops the drugs because he thought that now he has a normal blood pressure, he doesn't need more drugs. Okay, what are the secondary causes of hypertension? Secondary, which represents only 5%. But the importance of them is if you treat the cause, you don't get hypertension. And this is what we think is curable hypertension, only in 5%. Because if you take the cause, then the blood pressure will come to normality. Okay. Adrenal cortex, both increasing cortisol, Cushing syndrome, or hyperaldosteronism, which is Conn's syndrome, C-O-N-N-S, Conn's syndrome, which is high aldosterone, and both of them are increase the blood pressure through sodium, okay, through sodium content. Then you have the medulla, which is adrenaline producing, like pheochromocytoma, will give you high adrenaline, and this is again will give you hypertension. Then you have kidney disease, which is by and large the highest in the secondary renal disease. 75% of all secondary cases are due to renal disease. What is renal disease? Cause hypertension. How? One, glomerulonephritis, chronic pyelonephritis, systemic sclerosis, which will affect the vessels of the kidneys. Then you have polycystic disease. So on examination, if you find a big kidney, okay, with hypertension, always think of polycystic disease. And polycystic disease can be hereditary, okay? Treating that, then the blood pressure will go down. Renovascular disease, renal artery stenosis, okay? When you can hear a brewing in the abdomen over the renal artery, okay? And nowadays there are good ways of demonstrating the renal artery stenosis by MRA, which is magnetic resonance angiography, or even CT. These can show that the renal artery is constricted. Okay, it can be constricted unilateral or bilateral. This can be corrected. And there is a very high chance, I would say very high chance, not sure, very high chance that if this constriction is corrected, then the blood pressure will go down. So these are secondary. And then one is neglected is drugs, okay? Patients who are taking corticosteroids, say for rheumatoid arthritis, will have hypertension, okay? And then licorice. There are certain drugs, social drugs, like cocaine or amphetamine. This, if taken for a long time, they can precipitate high blood pressure. So this is important. Secondly, alcohol. Alcohol more than twice a day of 2 units. Above that, then this is a cause of hypertension. It is a cause of hypertension. So reduction of alcohol is essential if you have high blood pressure, and be it essential or secondary. Okay, there is the new trends in research has really came out with the role of renin activity, the renin-angiotensin system. And if we talk to the drugs now, the drug on top for hypertension are ACE inhibitor, which is angiotensin converting enzymes inhibitor, or angiotensin receptor antagonist. Okay, both of them are deal with the renin-angiotensin system. So the role of this part is very high. Okay, what is the role of sodium? Okay, if you have lower renin-angiotensin activity, then you are more susceptible to sodium, and then you get hypertension. Okay, even if you have a normal angiotensin aldosterone activity, if you take too much salt, then this is again is one of the contributing factors. I'm not saying it is the only factor, but it contributes to high blood pressure. This is why you advise patients who start antihypertensive to reduce salt. Okay, they can have salt, but without added table salt. Okay, that is some people almost stopped from salt. What is the two poisons? What is the two white poisons? The white poisons, the one is salt and the other is sugar. Okay, so it is important to remember that what we eat is what we pay for. So, having diagnosed hypertension, then what do we do? What do we do? First, we have to exclude secondary. Okay, simple. If it is cortisol or hyperaldosteronism like Cone syndrome, you get low potassium, high sodium. So electrolysis is one of the essential investigations we should do. Okay, if you suspect pheochromocytoma, you can do adrenaline levels. This is very easy nowadays, very adrenaline levels, you know. If you suspect hypercalcemia, like hyperparathyroidism, which is a cause of secondary hypertension, you do the calcium clearly. Okay, if you're suspecting the kidneys, you have to do the creatinine and ultrasound of the kidneys. Very essential to do the ultrasound to exclude polycystic disease, small kidneys, and big kidneys. Okay, that is another important one. Physical examination would have shown you if there is secondary cause like coarctation of the aorta, and this is a radiofemoral delay due to the narrowing of the descending aorta, giving you delayed impulse and very weak femoral impulse. This is again can be seen by angiography, and where is the lesion, how long is the constriction, coarctation of the aorta. Okay, so these are the investigations which are important. And the investigation not only to discover what is the cause of the disease, but also to the choice of drugs, okay? Because diabetic patients, for instance, need special drugs, special selection of drugs. If you have hyperuricemia, then diuretics like thiazides are not useful to you, or they will increase the hyperuricemia, giving you gout. Okay, so there are, if the lady is pregnant with hypertension, then ACE inhibitors are contraindicated, actually. ACE inhibitors are contraindicated with pregnancy, and they do better with calcium channel antagonists. So it's knowing the patient and doing some basic investigation can help you not only in diagnosing the secondary hypertension, but also choice of treatment. Okay, so what is the management? I would like to say it's management, okay, rather than treatment, all right, rather than drug. It's non-pharmacological and pharmacological. Non-pharmacology, we all dealt with it, like obesity, correction of diabetes, electrolyte disbalance, smoking, lifestyle, whatever. These are needing to be corrected for a good control of blood pressure. Okay, and this is important. Take time to explain to the patient that tobacco is dangerous. Okay, heavy drinking is again dangerous. Taking drugs, okay, dangerous, and this is often neglected. People don't ask the patient if he's taking social drugs like cocaine and amphetamine. Okay, so having talked to the patient at leisure, make him feel comfortable to tell you what is inside him. And after that, you can give him advice, okay? Be a friend to the patient. And if he feels that you are a friend and you want him good, then he listens. Not only listens, but also comply. So compliance with the drugs of hypertension is the most important factor in prevention of morbidity and mortality due to hypertension. Hypertension is notorious of doing thrombotic cerebral artery damage. It's less cause of hemorrhage. So it's if you treat hypertension, you treat quite a lot of other morbidities. Okay, what are the drugs? Because I think we are almost 5 minutes. What are the drugs which are available? These are 4 categories. Okay, we have the angiotensin. Okay, ACE inhibitor, angiotensin inhibitor, which is an enzyme which inhibits the angiotensin conversion, what we call ACE inhibitor, angiotensin converting enzyme, angiotensin converting enzyme inhibitor. So this is an inhibitor. The drug is inhibiting the angiotensin converting enzyme. Okay, this is number one class. And a similar class, but acts at different site, is angiotensin receptor blocker. So here you are attacking the enzyme, leading to an effect, and here you are blocking the receptor for this enzyme. So the effect is the same. Okay, the effect is the same. All right. The one difference is the angiotensin converting enzymes may be associated with cough, okay? And this is less with the angiotensin converting enzyme blocker, the receptor blocker, okay? So it's, this is important because these are the top 2 drugs. Okay, the third group is the calcium channel antagonist. Calcium channel antagonist. Okay, this is again is another important group, and the third group is thiazides or thiazide-related diuretics, like hydrochlorothiazide or chlorthalidone. These are thiazides, and these are diuretics, but it has a very potent antihypertensive effect. Okay, so how would we start? We start with the preferable condition is monotherapy. If you can get away with one drug, okay, that is fantastic. That is the set 1. Okay, if you don't, then you can add some drugs, 1 or 2, okay, from 1 or 2, then with calcium channel antagonist. Sometimes you need calcium channel antagonist with diuretics to put. Rarely we put a third drug, okay, third drug in combination. Okay, what are the contraindications for ACE inhibitors and receptor antagonists? Is pregnancy. The converting enzymes is notorious of causing severe cough, and which is less with the blocker. Okay, calcium channel antagonist is useful when we talk about pregnancy. Okay, because not all drugs with pregnancy, like ACE inhibitors and receptor blocker, these are contraindicated in pregnancy. And pregnancy, hypertension in pregnancy is a big chapter, because here we are dealing with two human beings, okay? And PET, which is pre-eclampsia, can go into eclampsia, which is the mortality is very high, convulsions and the rest of it. Okay, so these are the 4 drugs. What about beta blockers? Time gone by, we used to start with beta blockers, okay? But nowadays, we had evidence to show if you compare head-to-head beta blockers with calcium channel antagonists or beta blockers with ACE inhibitors, then the long-term risk and the long-term morbidity is not in favor of the beta blockers. This is why we don't use beta blockers now except when there is atrial fibrillation or ischemic heart disease, okay, or stable congestive cardiac failure, okay. The contraindications of beta blockers, obviously, the major contraindication is bronchial asthma, okay. So we have 4 drugs. 2 of them are almost of the same effect, but they act differently. The ACE inhibitors, the enzyme inhibitors, and the angiotensin receptor antagonist. The third is the calcium channel antagonist, and the fourth is the thiazide diuretic, hydrochlorothiazide or chlorthalidone. So these are the drugs, and once it is given, you have to check if these patients have side effects. Okay, the side effects which are attached to the patients or developed by the patients always is either generic, which goes to all people, or idiosyncratic, meaning that this particular patient has predisposition, maybe genetic or hereditary or what, to get this side effect. Okay, so the follow-up, if you are proposing to give drugs for life, give time to detect if there are any side effects, Okay, the other side of treatment is emergency treatment, or what we call malignant hypertension. What is malignant hypertension? Malignant hypertension is a sudden rise of blood pressure, maybe up to 200 systolic and up to 130 diastolic. This is usually associated with neurological disturbance and myocardial disturbance. Okay, with neurological, you can have a sort of encephalopathy, which is drowsiness, diminution of consciousness, and you can even have fits. Okay, as far as kidneys are concerned, they can be damaged. The heart can be damaged, give you arrhythmia, with this sudden rise of high blood pressure, and it can go into spasm, coronary spasm, and infarction, or it can go into heart failure. So malignant hypertension is dangerous because it causes fibrinolysis, fibrinoid degeneration of the arteries. And it goes in the eye, the retina, you get exudates, flame hemorrhages, and maybe papilledema. So if you get very high blood pressure with hemorrhages in the retina or exudates, even without papilledema, then this is malignant hypertension. Okay, this is an emergency. If you go to the books of medicine, you may not find a lot about it, but if you go to an emergency medicine book, you can find a good chapter about malignant hypertension, and this needs to be treated rapidly, usually by IV, okay? By IV, by nitroprusside, sodium nitroprusside, which lowers the blood pressure. It's given by injection. Action is very quick. Sodium nitroprusside, Prusside, nitroprusside, which is given by injection, or labetalol. Labetalol is an alpha and beta blocker. Both. Okay, it can be given in these 2 settings. All right, but don't lower the blood pressure too precipitously. Okay, the maximum we should do in the first hours is only 25% drop. If you do it more than that, you worsen the cerebral effect of the hypertension. Okay, so you have to be very careful. People who have a stroke, sometimes even not malignant, but will come with high blood pressure, and the house officer get disturbed. The blood pressure is 170 over 100 or 110. This is high blood pressure, and he thinks if he lowers the blood pressure, then the stroke will be better. If he lowers the blood pressure too precipitously, the stroke will be worse, because now with hypertension, this will increase the thrombosis or the bleeding. So this is malignant hypertension, which needs to be tackled, okay, separately and at the emergency level. So nowadays, with the development of emergency department and emergency specialty, we always think of a disease, what is the limit at the primary care, or where does the primary care physician, like family physician, stop? Where does the physician at the secondary hospital stop? And where would the physician in the emergency department stop? Okay, I don't think I have time for the other topic, which is rheumatic heart disease, and I hope I will cover it next time. Thank you very much indeed for being with me this morning, and look forward to seeing you on Sunday, next Sunday. Be blessed.